So wait, have you talked in the past about a very simple little supplement like niacinamide, which has a fair amount of published data for reducing skin cancer?
Right. They featured that as well in the symposium, that
Oh,
niacinamide now is actually something that they go into more of a genetic
certainly going to be well absorbed in
right?
that. I've mentioned that. It's
I'm sorry for spilling your secret this early, but
well,
I'm a big
that's
fan of
okay.
that.
That you know what, if I can't talk about testosterone cream on males because maybe that's good too. You know, the skin has a, aromatase. That's how you guys have plenty of estradiol in your skin. Did they talk about that?
Well, they were scared to talk about it.
Oh
There was somebody
no.
who spoke about it, and their answer is like, oh, I don't know, the literature doesn't back that up. We're scared about breast cancer and all these female organ
Uh,
cancers, so they're staying away from that topic. I mean, sure, dermatology, they're probably
well,
not
they don't
into.
know.
Yeah,
That's not their thing. But I'd love to see some data on if testosterone or DHEA cream for men would be anti-aging. I don't, for the skin, as a skin thing. I don't know.
right.
But I
That'll
don't
be
know why
interesting.
it wouldn't, since you have all that aromatase in your skin to turn it into
Right.
lovely estradiol locally. We don't want to give you systemic levels.
That is true. So, but yeah, I think we have a lot of interesting topics coming from you, Dr. Felice, that you will be discussing. Do you have a slideshow for us,
I
or are
have
you
a
just going to
little
talk about?
slideshow. I brought a little slideshow here, and then hopefully that will be sort of a starting point for conversation, which could probably go on for a while because I hope that everyone loves the topic.
My
Let me see
system
if I
keeps
can.
cutting off, so I apologize, but I'm glad that we haven't lost everybody. So,
We're
um,
all here. Will
We're
you
good.
record?
so yeah, we're recording. Yes,
Okay. Okay. So I made this little slide deck for you guys last night. So I hope you like flowers and purple.
we
Okay.
do.
Because oh good, because I love flowers and purple happens to be my favorite color. It's kind of tied with teal. Now, I always like to put a lot of flower pictures in my slides. Number one, because I do whatever I want. I hope you know that. And number two, because flowers are what? They're the reproductive organ of a plant. And so if you have a very unhealthy plant, you're probably not going to have a gorgeous flower coming off of it. And if you have a beautiful flower, probably there's a lot of good things happening in the rest of that plant to create such a beautiful flower. And of course, women have a reproductive system that is very dependent on the, well, you might say the sap or whatever, as an analogy, that is so critical. It's the ovarian hormones. And I came up, by the way, I don't know, do you guys have theories on why a woman has to go through menopause and lose her ovarian hormone production of estradiol and progesterone? I used to be, I don't know if any of you have your own theories, but I'll share mine in a minute. But I was really mad at nature for quite a few years. I mean, it's like, this is so mean to women. Like we fought so hard for all our rights. And then here we have, these beautiful hormones and then we lose them. And there's no great solution, to really replacing the ovaries. We have hormones, but it's not the same as having, 21-year-old ovaries. So my theory, and I'm open to hearing anybody else's theory on why women have to go through menopause, is that it's actually nature not being mean. They're trying to save us, women. Okay, so if you think about now, I'm an OBGYN. So I delivered thousands of babies during the 25 years in private practice that I was doing deliveries. And it became quite apparent, you need to have a really healthy body to have a healthy pregnancy. And as women got older, like into their 40s and they were pregnant, they were really high risk pregnancies. So the chance of developing gestational hypertension, diabetes, preeclampsia, preterm deliveries, growth restricted babies or macrosomic babies, all of that really increased so dramatically with the age of the woman. So if you look at ancient times, if a woman was in her like mid to late 40s, 50s, and older, and she was still fertile because she had ovarian function and she could still ovulate, those women, if they got pregnant, they wouldn't survive. Their babies wouldn't survive. So then the women would die from being pregnant. Their babies would not survive. So what's the point of that? And then because they would die from, pregnancy related complications, then they wouldn't be around to raise their existing children because the goal of nature, the prime directive of nature, is the creation of new life. And for humans to be successful with creating new life, you have to, as a female, you need, I mean, it's good to have the males too. I mean, we need them too, but the females particularly to be around to raise the children to their sexual maturity so that they can in turn have their own children later. Remember, humans are the only species on planet Earth that actually controls their own reproductive destiny, which I am in favor of, but that's not the way nature actually planned it out. So now I think nature was trying to be helpful by taking our fertility away so we wouldn't die from pregnancy related complications as we got older. But now that, time and, millennium have passed, we now separate reproduction from longevity and healthy living and healthy lifespans and everything else. So the fact that we cannot reproduce after a certain age, that doesn't mean that we can't have those hormones back. Understanding that those hormones are essentially, foundationally essential for the health of the body of a female, that I don't think I have to convince anyone here that hormones are good, right? You all have come to that conclusion that, well, just in case, you're still on the sidelines, unsure about if hormones are safe. Nature did not evolve for females to have bioidentical hormones that actually kill us, that hurt us, in any form or fashion. Hormones are protective. But of course, there was a lot of confusion with the Women's Health Initiative with using different chemicals, not human hormones at all. The conjugated equine hormones known as Premarin that came from the pregnant mare's urine and taken orally, which has some negative effects, like it turns into estrone predominantly, plus a lot of equine hormones that would never be in a human. And it increases blood clotting by 400%. And medroxyprogesterone acetate, which is an endocrine disruptor for progesterone, which increases breast cancer and a host of other bad things. So it would be like doing a study. I used to talk about strawberry flavored jelly beans, but now I'm going to switch and call it with trans fat, and then concluding that the fat from olives, beautiful monounsaturated fats, or from an avocado are evil because trans fat is evil. So we got to get over that. And people are afraid of the wrong things. No one should be afraid of bioidentical hormones. They should be afraid of endocrine disruptors and other things in life, but not bioidentical hormones. And so optimal hormones are essential at physiologic levels and rhythms. So that's what we're going to sort of focus on, because that is really a problem nowadays. And I'll tell you my thoughts on that. So everything matters based on dose, right? So let's talk about dose a little bit. Oh, first, let me just go through my little slides here. So estrogen is the mother hormone. It is the master of metabolic homeostasis, and of course, the master of all menstrual cycles. Now, what do I mean by metabolism? Okay, I'm sure you all know, but metabolism is the creation, production, distribution, storage, utilization of energy. Energy. And energy is the spark of life. In fact, when you think about it, if you have no energy in your brain, then you are brain dead. If you have no energy in your heart and you have no electrical signals, then you are dead, because you're flatlining for your EKG, right? So energy is the spark of life, and you cannot properly control metabolism, which is all about energy, which is about estrogen. So estrogen, now why is this like such a big deal? Because anyone who deals with obstetrics knows that, and this is all of life, but obstetrics is like the ultimate way of understanding life itself, because a woman who is pregnant needs to have an optimal intake of energy, also known as eating, to provide what is necessary for utilization of energy for herself and her baby. So how does appetite get regulated? How does the energy utilization get regulated? It's all estrogen. Estrogen regulates all these things. As a side note, you all are, I'm sure, very aware of the drugs that are so trendy now, that like Wegovy, and Manjaro, the GLP-1 agonists, and of course the other has GIP. But if we just talk about GLP-1 and the other one as well, but these other peptides, but GLP-1 does not get produced properly or function properly in an absence of estradiol, which is often like forgotten. That's one of the many reasons why women, as they get into the perimenopause and menopause, will gain weight like belly fat, and they get that matronly body instead of having their cute feminine body with the nice little waist. And they just do not have proper regulation of adipose tissue, appetite, and so on. And estradiol is like critical for that. In fact, there's now published data. I don't know if you guys know this. There's published data showing that GLP-1 agonists in females work better if they're given alongside estrogen therapy, okay? So this is like a critical hormone, and losing it creates metabolic disruptions throughout the whole female body. It's such a huge deal. And so to that end, nature needs to have every organ in the female body working optimally for successful reproduction. Now, remember, successful reproduction in the female human requires not just being successful with one pregnancy and one baby, but to manage and replace the species, you have to have multiple pregnancies. So remember, I'm not telling people to go out there and have a bunch of babies. I'm just talking about how the body is worked on. By the way, just FYI, I'm like the ultimate feminist here. Okay, I was out there when Gloria Steinem was like starting up. So I'm totally for reproductive, self-management, but this is reality. This is how the body was designed. So that's what makes it's so difficult to deal with contraception that interferes with normal hormones, because we need these hormones. That's the problem. Getting rid of our bioidentical hormones from our ovaries is not really great for women at any age, including teenagers. So, and that's another whole conversation we can have, is like, what the heck do we do about contraception? But in terms of fertility, you need to have every organ system working properly. And for pregnancy, you will have massive amounts of complications, which, by the way, are increasing by the truckload now. There are women having heart failure in pregnancy, dying of of strokes. I mean, this like really problematic here, because women are getting pregnant who are not very healthy. They sometimes get tricked into getting pregnant through fertility drugs and techniques, which I want people to have babies when they want them and they can't, but every woman should be optimized as much as possible. I hope you guys are doing that if you have reproductive age women who want to get pregnant, to try to get them healthy before, even if they go into IVF, because otherwise they're going to have high rates of pregnancy-related complications, and the babies they produce are not optimally healthy, and often will have metabolic problems from the day they're born, because it turns out the in uterine environment has a huge effect on the genetic expression from a metabolic point of view of the offspring. So there are estrogen receptors throughout the entire body. There's in every organ system. That's why when women go through menopause and they lose their estrogen, and by the way, I'm not talking today about progesterone. We could do that conversation another time because I'm going to touch on progesterone because progesterone is not just a sidekick of estrogen in terms of what it does in the uterus for like creating periods and shedding the lining. It has receptors throughout the body and has its own set of functions as well. So we'll touch a little bit on progesterone, but that's really at least another hour-long lecture. But in terms of like the estrogen here, it's everywhere, the receptors, and it's to maintain the health of the woman, not just through the pregnancy, but because humans have to reproduce multiple times so that she has multiple pregnancies and successful, childbirth, and then raises each child to their sexual maturity so they can then in turn reproduce. That's nature's plan. Whether we live by it or not is another story, but that is how our bodies were designed. So you need to be healthy, not just for one pregnancy, there are species of octopus that lay their eggs and then die. But that's not useful for humans. We can't like have a baby and die. That's not good. We have to have multiple babies. We have to live long enough to raise them to their sexual maturity. So we have to live quite a long time to make that happen. So we need all our organ systems working properly. And estrogen is like the hormonal glue that links all the organ systems to work in the same time zone through the circadian rhythm and to have optimization. And all of that is lost when we lose our ovarian hormone production. Now, I use the word estrogen, and sometimes I use it inappropriately, and probably some of you guys do too, because estrogen is not a hormone. Just like B vitamins are not a vitamin. You would never, like you're talking about, what is like niacin and like different B vitamins. No one would say you have a deficient of B vitamin. Like what B vitamin? What are you talking about here, right? So you have to then think, well, what estrogen are we talking about? So estrogen is a family of hormones, and you could say the same thing about fats. I mean, there are like manufactured fats that are evil, like trans fat, but even within the natural fats, there's omega-6 fatty acids, there's omega-3s, there's omega-9, then there's like saturated fat. They're not all the same, and the body uses them differently. And estrogen is a family of hormones, and we always use the word estrogen, and nobody knows what they're talking about. By the way, if I hear any of you saying the words, and you might, but if I hear it, estrogen dominant, I am going to have to give you like a little shove or something. I won't hit you in the head because that would be a bad thing for your brain, but I will be very unhappy because nobody knows what that means, like estrogen dominance. What the heck are you talking about? What estrogen? Is it progesterone that you don't have enough of? Where's the estrogen coming from? What type of estrogen? Just be specific. What's the problem? Because when people say estrogen dominance, people think, oh, estrogen is bad, like down with estrogen. Let's get rid of it. It's like, what estrogen are you talking about? So here we have the family of human estrogens. So at the top, I put the master estrogen, which is estradiol, known as E2. So estrogens, like B vitamins, have a letter E, not too shocking, and a number. See, there's 4, 1, 2, 3, 4. Like B vitamins, you have 1 and B, B1, that's thiamine, B2, riboflavin. So they have a letter, a number, a name. Estrogens have the same thing. So estradiol is the estrogen made by the ovaries, okay? Now, estrone, and estradiol is known as E2. Estrone is made by converting estradiol to estrone, and there's an enzyme that can convert back and forth, and the body decides when and if it wants to convert estradiol into estrone. So we're not smart enough to figure that out. We do not want to micromanage estrogen subtypes or how they convert one to another. Let the body do it itself as needed. So we give estradiol as the hormone replacement estrogen, and the body will turn it into estrone, E1, as needed. Now, estriol is the dominant estrogen made by the placenta in pregnancy. It's called E3. and the placenta makes a lot of estriol. It has a short life, half-life in the body. Estriol binds at least 80% to the beta receptor. Estrone binds predominantly to the alpha receptor, and estradiol binds in a balanced way to the alpha receptor, the beta receptor, and the G protein coupled receptor, GPERS, GPERS, which is predominantly a membrane receptor, both internal and external membrane of the cell. And it creates more rapid responses. But now they're showing that it could probably do some things involving the nuclear system too. The beta receptor and the alpha receptor are primarily nuclear receptors. So they work by creating a protein that gets transcribed on the ribosome to make like an enzyme or a protein. So that takes some time. And as well, the alpha and beta receptors can also be now found on membranes. We now know that. So it's not just a nuclear receptor that is being bound by estrone and estriol. It's also membrane receptors as well. So it's very complicated. And they interact with one another. Like if you have a lot of stimulation to the beta receptor, it actually downregulates the alpha receptor, which is what happens in pregnancy. So pregnancy is a very unique time, and we do not want to replicate pregnancy in a non-pregnant menopausal woman in different organ systems. And like, for example, in the arteries, that's more alpha. In the cerebral cortex, it's more beta. In the GI tract, it's more beta. In the bone, it's more alpha. But, they're all good and they're all balanced. In the immune system, and it's never one or the other exclusively. It's more a predominance. In the immune system, the innate immune cells, the macrophages, mast cells, neutrophils, they are predominantly alpha. The beta, the B lymphocytes that make like antibodies are predominantly beta. So in pregnancy, because you have such high estriol, which works predominantly on the beta receptor, high beta receptor binding downregulates the functionality of the alpha receptor. So basically, it's acting like an immune modulator. It's lowering the activity of the innate immune cells, like the mast cells, macrophages, neutrophils. So you have a lower production of immune response and inflammatory cytokines, which helps to prevent the immune system from attacking and killing the fetus or the embryo. So it's like an immune modulator. It's like just amazing. Like, you have this whole immune system that's modulated. And the reason I'm going into this is that that's also why women who are pregnant are less capable of dealing with infections, like if they get COVID or they get the flu or chickenpox, they are more prone to getting a worse outcome because their immune system, their innate immune system, is somewhat downregulated. That is why women, for example, with rheumatoid arthritis, multiple sclerosis, they often have significant remissions during pregnancy because of the reduced production of inflammatory cytokines, like certain interleukins, tumor necrosis factor alpha. They're suppressed because the innate immune system is suppressed by having all of that beta agonist binding by the estriol, downregulating the receptors on the innate immune cells. So, but here's the thing. A lot of people now are prescribing biased. And you may know I speak against biased, not because I think it's like, oh, terribly evil, but because it's not physiologic. It doesn't really make any logical sense because that is not what a woman has in her body ever. It's not even like pregnancy. I mean, it's all concocted stuff that sounded right at the time 40 years ago, but it doesn't make any logical sense now that we understand receptors and how they work and so on. And why would we put all that beta in to downregulate alpha? We love alpha. Alpha is not evil. Alpha is critical for having proper cardiovascular health, for proper immune function, for bone health. I mean, this like, not only that, the hypothalamus of the brain is predominantly alpha. That regulates things like appetite, okay, and sleep, and our circadian clock has and our nutrient sensors are predominantly alpha. The master clock is predominantly beta. So it's a blend. Nothing is all one or the other, but they interconnect with each other. They talk to each other. So we don't want to create an artificial environment, because I'm telling you, you are not smart enough to micromanage estrogen receptors. You know, we have drugs that are trying to micromanage that. They call them SERMs, and they all have potential issues. But why would we be doing this? You know, it was originally thought, well, women who are pregnant don't get breast cancer. Well, that's not true. Okay, sorry, that is not true. Women who are pregnant can get breast cancer too. They tend not to because they're so much younger. They're not in the age group that tends to get breast cancer. And so we don't want to create environments with hormones that never exist. I say this over and over. I'm a very simple thinker. Now that I have figured out in my own head, and I think it's true, why nature gives us menopause. It's not because nature doesn't want us females to have hormones. It doesn't want us to be fertile, because fertility can kill us as we get older, because being pregnant is a highly risky business, okay? Women can have it's like the ultimate stress test of reproductive age women is pregnancy. So the last thing you want is older women getting pregnant. And the whole thing is interconnected with the hormones. But when we separate it, when we separate fertility from the hormones, which we can do by giving hormones, what we would want to do is take away fertility, but maintain the hormones the way nature gave us the hormones, not create some new artificial, made up, completely concocted scenario of hormones for women. So if we could, and by the way, there are people working on this, replace the ovaries with a new set of ovaries. You know, there's been some research now where you can take like a little piece of ovaries out at a young age, which is not probably going to catch on. But if you did that and then you cryo preserve it, and then when a woman hits 50, you put it back in either on the ovary if you're actually looking for fertility, but probably not at 50, but you can just implant that piece of ovary like in the upper arm or in the upper leg, and that will then start producing hormones. And they're saying that you could then extend the reproductive hormones, but not reproduction, for another 20 years by actually putting back an ovary, a piece of an ovary like that. In addition, there are people working on cloning ovaries, because that would be the ultimate solution. Not have fertility, but have the hormones, okay? Because the hormones, the way they're designed by the ovary, are the optimal way of maintaining optimal health. We want to have the optimal health of a woman in her early 20s. That will not happen when you're 50 or 60 or 70, but that's a goal. Our goal is to have everything as optimal as in your early 20s. So the best way to go about getting even a little bit close to that is by replicating the hormones of a woman in that age group. Now, you may be thinking, oh, that sounds like Wiley kind of thing. And maybe, you know, she was pretty smart, and maybe that will be the way to go. The problem is that we have no data at all. We just have no data. And on the dosing, I'm not saying don't do it. I'm saying, you know, it's, you know, a little bit of a Wild West with that kind of a thing. But, you know, it has a lot of sense to it when you think replicating nature, what, you know, is the best way. If you think about creating a scenario that is completely against nature and failed horribly, and that's how, I mean, this is not the same, like biased is not like as horrible in any form or fashion like what I'm going to tell you. It would be ultra processed food, right? Like we can make food better than nature. No, that did not work out with ultra processed food. And saying that we can create a hormone environment for women after menopause that's better than the hormone environment that was created by the ovaries, I don't think so. But it's not horrible. It's just not optimal, okay? Because it just doesn't make sense. Once you understand that estriol, it can actually change how the immune system responds, and you're downregulating the alpha receptor, which is very important for many functions in the body. It's just illogical. You're much more likely to have leaky gut, because all women in pregnancy have leaky gut, and that's intended, but it's not supposed to be out of control. Pregnancy is like living on the edge, because you get leaky gut in pregnancy because it creates a low level of inflammation and a low level of insulin resistance. By having a low level of insulin resistance, you'll have a little bit higher glucose and you'll have a little bit more insulin. That will get more glucose to the fetus so that the baby can grow rapidly in a short period of time. And the higher level of insulin circulating will help the mother to put on fat, to gain weight, to produce fat without having to eat a lot more food. So it's nature's way of producing fat storage in the mother and glucose to the baby for baby growth. Well, what the heck would we want to reproduce that in a postmenopausal woman? And they have enough problems with weight gain. You don't need to give them a hormone environment that creates more weight gain and gives them leaky gut. So please do not use biased. No matter what some compounding pharmacy told you, it's illogical. But I'm always open-minded. And I'm not saying that there's no potential role for estriol in disease states, like maybe for multiple sclerosis, but that's not hormone therapy in menopause. That's using it as a drug. Now, I mentioned here on the slide, estetrol. So estriol is E4. It's a very weak hormone, estrogen, that's made in the fetal liver for a little bit of time during the pregnancy when the fetus is inside. So it's a fetal estrogen made by the liver, and it's a weak estrogen. When I say weak, what does that mean? It means that it doesn't bind very powerfully to the receptors. And that the reason that you need to know about it is that it's on the market now. It's in a birth control pill already called Nextstellis, and it will probably be out as a hormone replacement estrogen for menopausal women at some point in the next year or two, because they're working on it. The drug companies are working on it. And if you say, why would you want that? Well, to some degree, it's because pharmaceutical companies can make it. If you can make it, somebody will make it, even though it may seem a little bit illogical. But there may be a place for it in menopausal women. We don't know for sure. Now, alpha receptor for estrogen is not one form. We know at least two forms. There's two forms of the alpha receptor. All breast cancer seems to have one form of that alpha receptor when you have estrogen receptor positive breast cancer. So it turns out that estetrol does not bind to that specific form of the alpha receptor that is the receptor positive breast cancer receptor. So there may be a place for estriol in women who are dealing with breast cancer, even actively, who have estrogen receptor positivity. So estetrol may have a very specific limited role, but of course, if it comes out on the market, they're going to market it for everything. But I'm just telling you that for breast cancer patients, this may actually be a really amazing option. So I wanted to mention, I talked about like dose. So dose matters. So what's going on with dosing now in terms of hormone therapy? So hopefully I have convinced you not to use biased, okay? Now, what about how do you dose? So right now, the most popular way of dosing is a relatively small, sometimes not relatively, just really small dose of E2, estradiol, with a nightly dose of progesterone, usually like progesterone 100 milligrams. Now, is that better than nothing? Absolutely. I have a motto that includes bias. Any hormones are better than no hormones. It's like if you're starving to death, ultra-processed food is still better than no food. You'll starve to death. So any food is better than no food if the alternative is starvation. And any hormones are better than no hormones. Biased is certainly better than no hormones. And giving a very small dose of estradiol, I believe, is better than no estradiol. But it's important to know that dose matters, okay? So there's actually published data showing that Estradiol has a different effect on the immune cells, like the monocytes, macrophages, when it's low versus high. Now, why would this make total sense? So low doses are more pro-inflammatory and high doses are anti-inflammatory. Let's think about the menstrual cycle. When a woman has her periods, the estradiol is very low, okay? And that's when it's like in menopausal range for just a very few days. So during that time, it's a very inflammatory state in that the uterine lining is dead and dying, and this yucky lining, dead cells and stuff is coming out. And to that end, to help get it out, the uterine cavity is going to have a higher concentration of pro-inflammatory prostaglandins, which creates some amount of cramping. So a little bit of cramping with the menstrual period is normal. Extreme means there's way too much inflammation, way too much of the pro-inflammatory prostaglandins. And that's why drugs like NSAIDs can be useful, because they can block the production of the inflammatory prostaglandins. There are other modalities to deal with cramps, and I'd be happy to talk about that another day. But it's important to know that low estradiol is associated with a pro-inflammatory state. And high, when is it high? It's really high when you get the spike that precedes the LH spike, which then induces ovulation. So why would you not want to have any inflammation at that point? Because the sperm are coming, or they're already here, and we do not want to kill them, right? Because they're aliens, right? Sperm are aliens. They have different antigens. So you don't want the immune system to kill them. So you want to have a very anti-inflammatory state. High estrogen is anti-inflammatory. Low estradiol, I'm saying estrogen, it's estradiol, and I'm saying estrogen. So see, I always mess up too with that. Estradiol is what we're talking about. So estradiol, high amounts is anti-inflammatory and low amounts are pro-inflammatory. Now, just as a comment, estrone. So estrone, E1, is produced in menopausal women in a fairly large amount, in some women, in some, through the action of aromatase, predominantly in adipose tissue. So androgens, predominantly coming from the adrenal gland, by action of them, on them, by the aromatase, will convert to estrone. Now, when you have high inflammation in the menopause, because menopause is associated, if you're not replacing hormones, natural menopause, as a pro-inflammatory environment, like they call inflammaging. You have a lot of inflammation because the immune system is dysregulated, because the gut, the microbiome of the gut changes in menopausal women to become dysbiotic, and they all get impaired gut barrier, aka leaky gut, which creates more inflammation. The immune cells are more triggered to respond with higher amounts of inflammatory cytokines, because the alpha receptor on the innate immune cells is more activated because estrone activates them more. So estrone is very pro-inflammatory. It doesn't, if you think of estradiol as the grand modulator of the immune system, it turns on and off inflammation as needed. Estrone is like the on switch, and to some degree, estriol is like the off switch, but you want to have estradiol, which modulates the on and the off switch appropriately. And so we definitely want to have estradiol. Estrone is not evil. We want estrone, but we don't want overproduction. We want the right amount. In postmenopausal women who have especially a fair amount of adipose tissue, because weight gain is so common, and they have a lot of inflammation, inflammation upregulates aromatase in fat tissue. And so you get the conversion of these androgens from the adrenal predominantly into estrone. So you have this estrone dominance, you might say. Okay, and estrone activates the alpha receptor on the innate immune cells to create a more pro-inflammatory environment. And it sort of expands the inflammatory state. And that can accelerate if you develop a breast cancer in the breast. it activates, because it's, remember, it's on the alpha, it activates the alpha receptor, both forms of the alpha receptor. Breast cancer has one form of alpha receptor positivity. So estrone that's produced both in peripheral fat and in the fat of the breast itself can actually stimulate further growth of the breast cancer. That has nothing to do with estradiol, okay? Nothing to do with ovarian or exogenous given estradiol. And in fact, just so you know, there is no published data showing that giving estradiol to a woman with breast cancer actually accelerates the breast cancer growth. But I'm not advocating to do that, okay? Because hypothetically it might, but it's interesting that there really is no clear data to show that. But estrone produced in the breast fat and in the peripheral fat will actually potentially, more than potentially, will activate and grow breast cancers. So that's important. But in terms of estradiol, what's happening now is that there are a lot of doctors who are very uncomfortable giving physiologic doses that are going to replicate something like the average level of an estradiol level in a normal menstrual cycle. It's not like, what's the average level? It's sort of like not, you know, the lowest part of the follicular, not the highest part of the luteal, not the spike, but something sort of in between. So I kind of go with around, if you can get the patient to do this and they're willing to, around 100 picograms per mil of estradiol, but at least over 50, okay? And what's the high? I don't have a firm cutoff, but usually in the 150, 160 range. But if somebody has like 180 and they're doing great, there's nothing wrong with that, okay? A luteal phase estradiol level can easily be over 200, just so you know, okay? So we want to be in a physiologic range. But if you go below 50, then you're not going to have enough to really maintain and grow a lot of the tissues, okay? We know that you can't maintain the vagina at all with a systemic level less than 50. So I try to always get, please, unless the patient says I can't stand it, I don't want it higher, then of course you do what the patient wants. But you know, the goal is to be at least over 50 and sort of towards 100 if possible, but it can be somewhat below, somewhat over. This is the most personalized non-precision medicine ever, okay? I call it ballpark medicine. But we don't want to be super, super low because that doesn't make sense. What we're trying to achieve something here. We want all the receptors all over the body to be activated and to do their optimal thing. That means optimal doses. And we don't want to give such a low dose that we're actually, maybe feeding inflammation. That's ridiculous. So what's happened is that there are so many people giving estradiol, a lot of them through clinics that are online, and they want to make it cookie cutter and really simple. So they're giving really small levels of estradiol, and then they're giving nightly doses of progesterone. So what's the problem with that? Well, progesterone downregulates the estrogen receptors. So basically, it's kind of like the off switch. If you look at a normal menstrual cycle, in the luteal phase, the proliferative growth of the uterine lining stops because of the progesterone. So progesterone is kind of like the brakes on growth, and estradiol is like the gas. But why are you trying to block growth factors? So here's the thing, it's a total body package. If you give estradiol, it's going to go to every organ. It's going to be good for the brain. It's going to be good for the cardiovascular, for the musculoskeletal, for the genitourinary, for the skin. It's going to be good for all the organ systems. And it's going to go to the uterus. If a woman has a uterus, we can't put up a sign at the uterine artery saying hormones do not enter. It's going to get into the uterus. And in the uterine lining, it will create growth factors that create proliferation. And here's the thing. If you grow it, you must shed it. You can't have unending growth of the uterine lining. It's just going to topple out, and then you're going to have random bleeding. So if you're going to give a more physiologic level of estradiol, you will have growth of the uterine lining. It's just part of the package deal. And if you grow it, you must shed it. And if you give enough estradiol to create the growth effects throughout the whole body, then you're going to grow the uterine lining. And if you keep trying to give higher and higher amounts of progesterone to try to knock down the growth factors of the estradiol, at some point you're going to create sort of a hormonal havoc situation that's not physiologic at all. So what is, among the many, many amazing benefits of estradiol, which, I'd be happy to give a talk on just everything that estradiol does through the body, including the mitochondria and every organ system. It's the most amazing hormone. And, works to make thyroid work. It works to make other hormones work, including melatonin works better when you have estradiol on board. Everything seems to. So in terms of getting growth factors, like think of brain-derived neurotrophic factor, nerve growth factor, VEGF, vascular endothelial growth factor. You need to have growth factors for rejuvenation, repair, replacement. Well, you can't get optimal growth factors if you don't have an optimal dose. And estradiol is responsible for creating all these growth factors, and it's going to grow the uterine lining. It's a package deal. Now, I'll tell you something that I am really, really wanting to promote, but no one is doing this. But it would be when a woman hits around 50, or when she's no longer planning to have children in her 40s, say, she should have an optional endometrial ablation. Like if a woman wants to have optimal hormones, but she doesn't want to bleed, and you want doctors to be able to prescribe hormones in a physiologic dose so that they get optimal benefits, but they don't know how to handle bleeding or irregular bleeding, why can't women have their uterine lining ablated, essentially destroyed, either with radiofrequency or thermal ablation when they no longer care about it? You're not taking out the uterus. It is a 15-minute procedure. And when you think about what women can do optionally, like I have next door to me here, I have a plastic surgeon's office. So a woman at any age, man too, but I'm just talking about women, they're the biggest users. They can walk right into that plastic surgeon's office and ask for all kinds of surgeries that have essential risks to them, that can require hours and hours under anesthesia. And that nobody thinks anything of it. It's like, I want a facelift. It'll take 10 hours. Okay, fine. Or whatever. I want breast implants. I want liposuction, you name it, and they get it. Okay, and all of that requires general anesthesia. Nobody blinks an eye. You want it, you get it. Well, why can't women have endometrial ablation on demand? 15-minute procedure, extremely low risk. I don't get it. I think we should band together and create some kind of a program to get this on, to get this normalized, because you cannot get optimal results with non-optimal dosing. I am sorry, but that's the way it is. And when they did, for example, the ELITE study and the KEEP study, I don't know if you guys are familiar with those studies. Those are the main studies that came out that were not just retrospective. They were placebo-controlled, double-blinded, prospective studies that involved cyclic progesterone. Okay, they were not static dosing. The dosing of the estrogen component, which sometimes included estradiol and sometimes had oral estradiol and sometimes had too low a dose and included some Premarin. I mean, don't even get me started on the doctors who created those studies had no idea what they were doing, but they meant well. But those studies use cyclic progesterone. This static dosing of nightly progesterone is so illogical. It's non-physiologic. Like, we tell people to eat at the right time of day, to go to sleep at the right time, and so on. We know that circadian rhythm matters. We know that all rhythms matter. So what the heck are we creating this total non-existent regimen of hormones where we're giving estradiol every day and progesterone every night? It's illogical. It's not physiologic. And you're purposely trying to block the growth, the growth factors from coming into play that are so restorative for every organ system, including, unfortunately, the uterus. So if we could do elective ablations, it would solve that problem. You would have spotting, if at all, or no bleeding, which is the majority of cases with an endometrial ablation. This should be what we're doing. We shouldn't be giving hormones in a way that's non-physiologic, that doesn't allow estradiol to have its optimal benefit, because you're knocking it down by giving all that progesterone every day. And progesterone and estradiol, they go through a beautiful rhythm that actually can matter. Like, we know that women who are in the reproductive years, when they have irregular cycles, they have more cancers, cardiovascular disease, premature death. Cycling matters because when you have the cycles, when you show the beautiful menstrual cycle, the rhythm of the hormones is more than just to make a menstrual cycle. When we have like the different spikes of estradiol, progesterone, they're upregulating tumor suppressor genes. They're like estradiol as it's rising, it actually upregulates its own receptors, progesterone receptors, thyroid receptors, testosterone receptors. Higher amounts of progesterone downregulates estrogen receptors and testosterone receptors. So, I mean, these receptors are dynamic. They're not fixed structures. They have receptivity that's altered by the rhythms of the hormones. And I have a little course that you're welcome to access if, you know, I can, if you're interested. I'm not pushing it at all, but that talks a little bit about how to include a rhythmic dosing using just standard commercial products, you know, that is not going to get anybody into trouble. It's a very mild modification if you're even interested in that sort of thing. But just creating the rhythm, not like getting the rhythm of ups and downs in the cycle, which is probably the way to go at some point, but just having the progesterone two weeks and then not 2 weeks, more or less, and like two weeks out of the month. By having that, you're actually helping to reboot the receptors. I don't know if you know this, but when you give all the time, you get tachyphylaxis of your receptors. So often women after years of, or a few years, not that many, on constant dosing will actually stop having proper response because it's like never has a chance to reboot. And this idea that people have manufactured where you take 1 day off a week or something, where's the data for that? There is none. So stop making up your own programs and whoever comes up with this stuff. Stop trying to think you're smarter than nature. I know I am not. Let's try to be somewhat consistent with nature here. Remember, nature took away women's hormones, not because nature didn't want women to have hormones. Nature didn't want women to be able to reproduce and die from pregnancy. So we want to give back hormones. We want to give back bioidentical hormones, not stupid stuff like Depo, you know, like Provera, medroxyprogesterone acetate, or equine conjugated estrogens. And, you know, there's still products out there like, what is it? I never prescribe it. Duvray, I'm forgetting. It's like Duvet. And it was off the market. Now it's back. It's a combination of, it's an oral product, Premarin and a serum for estrogen that acts as sort of on the progesterone receptor and blocks the growth of the uterine lining. It's so concocted and so dumb, and so many GYNs are prescribing it because I guess the drug rep is very nice and persuasive, but it's like non-physiologic. It makes absolutely no sense. So I'm just very simple thinking. Just try to replicate nature. Don't try to create food that's not natural. Don't try to create environments that are not natural. Don't try to create hormone regimens with non-human hormones that are not natural. So in terms of what's out there in commercial products, I'm sure you already know this, but there's like patches and they're all generic now. And some of them, they're not identicals. So if you get a patient that's on a certain patch that's like Dottie, that's, you know, or, you know, the Mylar or Liletta or whatever that other one is, you know, you get one that has, they're generic, but they have a brand name to them, and the patient does well on it, please try to get them to have the same one, because I've had patients that the pharmacy switched them to a different manufacturer and everything goes whoop, not good, because they really don't absorb the same, and they're allowed to have variance in actually how much estradiol is even in the patches. So it's created some problems. The other thing is that you're more likely to have sometimes breakthrough bleeding on the patches because the amount that's delivered into the system on day 1, 2, 3 and a half is not going to be the same. So you'll have more on day 1, less on day 2, less on day 3, and so on. And for some people, especially as the progesterone is on board, will create instability of the lining, and then they'll start having breakthrough bleeding, and then you won't know what to do, and then you have to send them to me. And you won't want to do that because I may not even be in your state. So, you know, then you have to find a tolerant GYN, which is really tough, which is why people try to give doses that won't create growth. But that's not a solution because you're not dosing people appropriately. You don't want to give a subtherapeutic dose. You're not going to tell people well, like someone walks in and says, I don't want to sweat, but I do want to exercise and have all the benefits. It's like, what are you willing to do? Well, I'm willing to exercise 5 minutes once a week. Okay, you know you're not going to get the benefits. What kind of benefit do you get out of exercising and you don't even sweat 5 minutes a week? So dose matters and so on. So in terms of the estrogen doses, for an older woman, I would usually start at a lower dose and then work up. But the goal is usually to get to the highest dose, because the highest dose is not even a high dose. So, and everyone absorbs differently. So I do measure. I feel that you have to measure doses. And for the patches, I tell them to get the level tested the day after they put on the patch for consistency, sort of a middle of the road. Now, in terms of gels, there's the two commercial products, estrogel, which you wipe up your arm, and the 2 pumps is usually what's needed. That's what they use in Europe all the time. And the Divigel, which comes in a variety of strengths. And usually you end up with, to get any kind of good level, the 1 or the 1.25 milligrams. And sometimes with the highest doses of these, you still can't get into a reasonable level. So everyone absorbs differently. The skin is supposed to be a barrier. Talking about dermatology earlier, the skin is supposed to be a barrier. It's not supposed to be a sieve. And some people don't absorb well. Their skin says, what the heck? I'm not here for a hormone delivery route, and it doesn't absorb. So you have to then go to bioidentical compounded, which I use all the time too, and that's what I put on my face to try to reduce wrinkles. Estradiol is very anti-aging of the face. It's very anti-wrinkling, and it reduces skin cancer, and it also reduces like brown spots. Inflammation is what causes melasma, okay? Or estrone, like from birth control pills, or inflammation, like pregnancy is an inflammatory time. It's a very interesting time, pregnancy, because it's a blend of anti and pro-inflammation at the same time. That's why we do not want to replicate pregnancy in a non-pregnant person. Pregnancy, remember, is the ultimate stress test for women. Femring is still around. It's not usually available. You have to, pharmacy can order it. It's not on any formularies, and it's very pricey. But for some people, they want it. It's, it comes in a ring made out of silicone, and it comes in a precursor estrogen, and then it turns estradiol acetate, and then it gets converted. But, some people, they really love it, and it may or may not deliver enough. Usually, if you're going to use it, you need to use the higher of the 2. It only comes in 2 doses. And then oral estradiol, I almost never use. It has about double the risk of blood clotting. But younger women, like in their earlier 50s, they have low risk for blood clotting anyway. You can actually, not that I would do it particularly, but you can give in healthy women birth control pills up to the age of 55. So you certainly could give oral estradiol tablets, but they're converted through the liver into estrone. And like I already told you, you don't want a body just full of estrone. You want estradiol. You can only get estradiol in when you give it topically. In terms of pellets, just as this is on here, I'm anti-pellet, and the reason is because it's not physiologic. You can never get physiologic dosing that I have ever seen or heard of with pellets, because you get too much, then maybe it's right, and then it's too little. So the body doesn't take what it needs. The body gets what it gets. And so pellets are convenient and so on. I'm sure some of you love pellets, but I do not recommend them, because like I said, I'm always trying to mimic nature, and I don't think pellets do that. Women do feel really good on pellets initially, but usually they will end up having all kinds of bleeding problems, and many of them end up with what would be considered unnecessary hysterectomies, because they get into so many bleeding troubles that nobody can manage. Troches, I do never use troches for estradiol, because it's really like giving it orally, and it liquefies and then it's mostly swallowed. So I do not care for troches for estradiol. I don't use troches really much at all. And, gels and creams and patches, patches are not obviously compounded, but I use a lot of compounded estradiol. That when you use compounded, you can put it anywhere you want. You can concentrate it any way you want. You can, usually if you give compounded estradiol, you'll give it twice a day. Some people actually need it even more than twice a day, because it's not time release. Okay, there's no time release. It's not going to last for 24 hours if you put it on once a day. And some people you have to put on even more than twice a day, but most of the time twice a day. There's no published data on where to put it. So people put it in different places. They put it on the inner arm, the upper arm, the inner thighs. You know, people can put it anywhere they want. That's why I figure, what the heck, I'm going to put it where it's going to give me the most bang for my buck. So I'll put it on my face and neck because it's anti-wrinkling. There's published studies showing that you can reduce wrinkles in 2 weeks. You'll see visible reduction of wrinkles in 2 weeks by putting estradiol on the face. Now, talk about estriol on the face. So skin is more beta than alpha in terms of the receptor type. So a lot of times people will use a small dose of estriol on the face, and I'm not opposed to that at all. It's comparable to using estriol intravaginally, which is a skin. The vagina is modified squamous tissue. But remember, for both of those places, that there are other components of skin besides the epidermis and so on. There's also things like fibroblasts and other components of skin and hair follicles, which have alpha receptors. So my personal choice, if possible, is to give estradiol to the skin, to put it on the skin, but estriol is still beneficial for sure intravaginally as well, which is very common in Europe, but the bladder is more alpha. So when you're trying to improve bladder health, you're actually better using estradiol intravaginally than estriol, but they both can be helpful. Now, this I put here, this is from a paper that I wrote, was published about, well, goodness, I think almost 2 years ago in Mayo Clinic Proceedings, I believe. And it just kind of goes over some like basic kinds of hormone use. I wrote this for like people who are not, you know, going to be doing sophisticated things or rhythmic things, in the sense that you're going to be having variable doses through the cycle, and as well that using nothing compounded here. This is like, you know, Mayo Clinic Proceedings. They're not doing compounded stuff. I have to if I want to get published, I have to temper my enthusiasm about some things, okay? Because otherwise they won't publish it. So it's really important to just appreciate the critical importance of hormones. They're so amazing. Now here, in terms of the rhythmic, this is one study, and there are others, that there's some that show that you get better bone when you have rhythmic progesterone. This one study showed that giving rhythmic progesterone 14 days each cycle reduced myocardial infarction. Okay, so I want you to, and so why would you do cyclic instead of daily? Number one, if you want to get a better dose to create growth factors and all the other amazing things like mitochondrial rejuvenation, you want to work on having better glucose transport, lipid control, brain health, immune function that's regulated. The magic is in the dose. So you have to give a physiologic dose. If you give a physiologic dose, you're going to grow the uterine lining. And in order to try to keep it from growing, you'd have to give massive doses of progesterone. This is not sensible, and it probably won't work, and you're going to get breakthrough bleeding anyway. So you have to give a physiologic dose of estradiol to get optimal benefits at every age. And if you grow it, you must shed it. So you do what nature does best, which is progesterone for 14 days each cycle, and you can do 200 milligrams. Sometimes, you know, people need higher. Some people can't tolerate even 200, and sometimes you have to use cream compounded progesterone. So this is where the nuanced approach is and the highly individualized approach. But the vast majority will do fine on 200 milligrams for 14 days, and they'll have regular bleeding. If they have breakthrough bleeding and they're using a patch, it's probably because the patch has not stable levels. Switch to a daily gel or daily twice a day dosing of compounded estrogen. Sometimes you need to have more estrogen to maintain the stability of the lining. And sometimes you may need to have higher progesterone. So these are the nuanced things. That's why it's not for every single person who's in the medical profession to prescribe, because you have to be dedicated to the cause, both the patient and the provider, that they really want to try to optimize health by giving the optimal amount. So it means giving enough to actually create the outcome, like you want to get, you want to have exercise to get the outcome. You want to have sleep to get the outcome. You want to have hormone dosing to get the outcome. So you want to have enough estradiol to grow the uterine lining if you're going to get all the other growth factors. And it's not just about growth factors. It's all the other amazing things that estradiol does throughout the body, which I have, lots of lectures on. Because it does everything. It's involved in every organ system and basically every single function. And so if you grow it, you must shed it. And also doing the on-off of the progesterone actually helps to reboot the receptors so they don't get tachyphylaxis, and that you have proper up and down regulation, proper function, so that you get optimal outcome. So in order to, help every one of your women to have optimized health through their entire life, so they can be what I call myself, a super ager lady. So that the goal, I'm not there yet, okay? The goal is that at 95, you can do most everything that you did at 35, not identically, you're not going to maybe climb the tallest mountain, but you can travel the world. You can have intelligent discussions. You can watch movies that have complex plots, read complex books. You can talk about every subject under the earth. You can learn new things. You can take up new hobbies. You can have a career that's ongoing. Okay, so your life is excellent. And I always tell my patients, the warranty's up at 100. At 100, we'll have to renegotiate a new warranty. But I think this is doable. And, you can do all these other things. You can incorporate, metformin and rapamycin and whatever, but none of those make any sense if you don't have optimal hormones. I say go for the low-lying fruit, and that's what this slide is about. Eat at the right times and sometimes fast. Work on exercise, fitness, love, and community. Get sunshine, laugh, just be active, work on your HPA axis so that you don't get too stressed out. Try to get enough vagal tone, do all the things that you need, have a mind-body practice, eat the right foods, work on, sleep, eliminate the exposures to environmental toxicants as best you can. Do all of these things, and then an optimized hormones before you even think about doing all these other extraneous things, in an absence of addressing the most fundamental things for healthy longevity. And I'm open for questions. If anyone's awake.
Yeah, wow. Where did
I have a question, actually.
Go ahead.
Dr. Gersh, thank you very much for this presentation. It's so wonderful. The question is, as estrons interconverse with estradiol, as you said before, and if the women will still keep the estron production, estron will convert to estradiol as well. And we didn't talk about the estrogen metabolites.
Oh,
So
well,
what do you... Yes.
No, I didn't mean to interrupt. I was just jumping in because you got me all excited.
Yes. Yeah, so I wondered how the estrogen metabolites come in, since the menopausal woman will still keep the estron going, and you're giving them this high dose estradiol. So how do we navigate those?
Okay, so why do postmenopausal women make all that estrone? Okay, it doesn't have to be that way. Okay, in an ideal world, you would start your perimenopausal women. Remember, menopause is a ridiculous label. It's all about periods. That's not what menopause is about. Menopause is all about hormones and the ovaries. The uterus is just one target of those hormones. right? Have you ever had the question, well, if I'm in, if I have a hysterectomy, does that mean I don't go through menopause? It's like, I think you do. Okay, so we, we don't, if we think about as a spectrum of ovarian decline, if you can start the hormones early on as supplementation, so perimenopause is hormone supplementation, and in the menopause, when there's the official menopause, when the ovaries are not making any hormones, estradiol and progesterone, they still make testosterone, then that's hormone replacement. So it goes supplementation, replacement. The reason women get all that adipose tissue and make all that estrone is because they have loss of their estradiol. And so their adipose tissue has no controls. You have loss of control. You end up producing a lot of adipose tissue. It goes into the middle and the viscera, and you have all that inflammation and and leaky gut and the inflammation and dysregulated immune system. The inflammation activates, upregulates aromatase, and then you make all that estrone. None of that has to happen if you do all the lifestyle stuff to lower inflammation, the right diet, sleep, exercise, fitness, all those things, avoidance of environmental toxicants, and you give them physiologic doses, similar to a menstrual cycle. You give them the estradiol. Estradiol modulates the immune system, so you don't have this systemic-wide inflammation, which upregulates aromatase. So you're lowering the risk of breast cancer, you're lowering the risk of growing more adipose tissue and around the middle, you're lowering the activation of the aromatase enzyme, and you're lowering the production of estrone. So the goal is prevention. But say you get a woman, she's already kind of obese or very overweight, she has all that belly fat, she clearly is an inflamed person. You got to work extra hard, but it's totally doable. You have to do like a detox, using the nutraceutical company that you like to work on gut health, liver health, work on improving detoxification pathways, which will of course involve estrogen metabolites. So you have to work extra hard for women that you don't get to work with them from the get-go, like from the time they're in their mid-40s on, so that you have to try to, make up for lost time. So, but it's definitely doable. So you have to work on weight loss, exercise, all the lifestyle things, but get them onto a physiologic dose of estradiol to control their immune system and to start lowering, get their, improve their gut microbiome, heal up the leaky gut, and help them to stop having the systemic inflammation, which drives the estrone production. So that this doesn't have to be, it's nature at its worst for women that, but we can control this. In terms of estrogen metabolites, when you talk about the different phase 3, phase 4, phase 2, phase 1 and 2, they're like more in the intestine, 3 and 4 more in the liver. And then you have the estrobolome, where you have enzymes like beta-glucuronidase and so on, which I'll touch on. So you want to do everything to restore functionality of the GI tract, detoxification. I do a lot of ultrasound ordering of the abdomen, looking at I look at the gallbladder. A lot of women have gallstones. You want to know that. And also their liver, because now it's called metabolic steatosis, non-alcoholic fatty liver, is highly prevalent in women who are in the menopause, and they all have impaired gut barrier. They all have dysbiosis. So you got to work extra hard. And the thing that works to help restore proper immune function, lower inflammation, and lower ectopic fat in the liver and elsewhere is by doing Prolon, the fasting mimicking diet, along with time-restricted eating, and as much as you can to get towards, as a goal, high-intensity interval training. You can actually get rid of this ectopic fat, but also the visceral and belly fat. So there are ways to do this. And of course, there are drug therapies now, like, Wegovy, Mounjaro, and so on. But that's another conversation. I have concerns about right now the amount of lean body mass that gets lost along with the fat, and the lack of longevity in terms of people sticking on these drugs, based on Wegovy's own data, out of Novo Nordisk. I'm looking at their data, and it's not very appealing right now. So I'm not sure that this is going to really be the solution for everybody. And we can create our own GLP-1 naturally by eating a really high fiber diet, exercising, and having adequate estradiol, and then incorporating fasting, mimicking diets and such. So it's really doable. But, women who are already in a bad metabolic state and they're in menopause, they really need high intensive care to work on getting proper estrogen metabolites. The biggest risk for breast cancer in menopausal women is weight gain and obesity, the absolute biggest. And of course, that goes along with systemic inflammation. In terms of the gut microbiome, it's an interesting thing. Beta-glucuronidase that breaks down and recycles estrogen back into the circulation is actually a benefit in some circumstances. Like, why would the gut even do such a thing? Okay, so I always go back to reproduction and fertility. So what women other than menopausal women have no estrogen production? Breastfeeding women, postpartum women. So how does nature provide enough estrogen for women whose ovaries are not functioning? It's through recycling the amount that you do have through the gut, and the beta-glucuronidase is actually beneficial for postpartum women to increase their estradiol levels. So, everything that sort of seems wrong is actually right in a different circumstance, okay? So nature didn't put the ability to make beta-glucuronidase and recycle estrogen for no good reason, but it actually can help some women in menopause too. So don't think down with all beta-glucuronidase. Sometimes it's very, very beneficial in terms of upping the amount of estrogen circulating. But what we don't want is having all kinds of estrone and lots of inflammation, and then having the wrong metabolic byproducts of estrogen detoxification. So that's why women who are metabolically unhealthy really need your care so intensively. And sometimes before starting hormones, you may want to do like a detox before you even start the hormones to try to help to improve gut liver health. But the reality is that it's one of those catch-22s. Without having estradiol on board, nothing can work properly. So even if you want to start a little bit low initially and then work your way up, and there's no data, you know that we're on our own for so much of these things, and because no one's doing the studies. So we have science, but we don't always have clinical data. But our patients live in the here and now. You can't wait for the clinical data. When the heck is that coming? And by the way, yesterday, it was really horrible. The Menopause Society came out with a statement, a letter that I got in my email that was saying how there are these doctors online. I don't know if they were talking about me. I don't know. I don't think I'm on their radar, but I don't think I'm on their radar. But they talked about these doctors online who are promoting estrogen for functions, for benefits other than night sweats, hot flashes, bone health, and genital urinary issues. And things like brain health, cardiovascular health, any musculoskeletal benefit other than bone. They said, no, you cannot do this. And we are the definitive word. Who the heck are you anyway, Menopause Society? They said, we are the definitive word. I didn't elect you. So anyway, this is what's out there, you guys. If you're doing hormones, the Menopause Society wants to stamp you out. They want to stamp me out. So, it was a very horrible letter, but you can probably find it online that they put out yesterday from the Menopause Society. But it just, oozed out arrogance and ridiculousness. But that's what's out there.
You know that they're big pharma backed. You know that, right?
Well, I know if you go to their place, all the exhibit hall stuff is 100% big pharma. So yes, they are big pharma backed. Yes.
So
I have a one quick question, then I will shut up. How about vaginal dryness and estriol?
Okay, vaginal. So estriol is fine for vaginal atrophy. I actually
come across the border illegally. You've got to stay in Mexico. You've got to go back through proper channels.
Oops. Okay. So I personally prefer from estradiol for the reason I said, because the bladder is more alpha than beta, and estriol is mostly 80% beta, and estriol is also a weaker binder to the estrogen receptors, but there's plenty of data showing that estriol is beneficial. So estriol is totally fine for vaginal like rejuvenation. But if I had a choice, I actually prefer estradiol because it works on fibroblasts and it works better on the bladder itself. But estriol is very good. I also use vaginal DHEA.
Very good. Thank you.
Okay. There's a couple of questions in the chat. If you could take those, if that's okay.
Well, can you read them to me?
Yeah. Yeah. So let's see. When do you measure estradiol relative to your last dose?
Okay, so there's no clear, it's a little bit like thyroid, like what do you do? So I usually say measure it in the morning before you apply your first application. If for some reason you can't do that, then get it at like the tail end of the day. So I don't actually want to get it like within an hour or two of application. For the patches, if someone's using the patches, I say the day after it's put on. So that's how I do it. And then I usually then, I think, okay, this is like around the average level or a little bit lower than depending on, what the product is. So I then kind of make my estimates of how it's doing at that level, because I don't want the lowest of the day to be too low. Okay. I'm not afraid of estradiol. I would rather a little bit higher. I mean, not crazy high, but a little bit higher than too low.
Okay. Is there an interference between estradiol and replacement dose of levothyroxine?
No, but it's very interesting though. Estradiol will actually have a lot of benefits on thyroid. So there are receptors on the thyroid gland for estradiol. So when you have adequate estradiol present, often the thyroid gland will work better. And I've had patients that had borderline hypothyroid, like maybe they had a TSH of 5 something. I got them on optimal hormone replacement. They had maybe estradiol levels of essentially 0. And then I got them up to around 100 or so. And their TSH went down into the normal range just by getting their estradiol replaced properly. So I wouldn't like take someone who's severely hypothyroid and think I'm going to treat them with estradiol, but someone who has subclinical hypothyroidism, and they're just getting started and their estradiol level is like 0, I will say, let's try this for a month or two. They're not like dying from hypothyroidism. They're just like, it's borderline-ish or mild. Then, because often it will actually improve. The other thing that's interesting is that in order to make thyroid, you need to have certain very critical nutrients. So often the gut isn't working well without estradiol and you don't have proper digestion. And by getting the estradiol on board and then giving them some general supplementation, like if they need it, if they're actually iron deficient, or if a little bit of food that have iodine in it, or small amounts of iodine. I'm not into megadosing at all of iodine. And selenium, zinc, that type of thing, the like essential nutrients to make thyroid hormone, that they'll actually, that's another reason why they can actually repair their own thyroid gland. So if you're just starting someone on estradiol and they're already on thyroid, I wouldn't make any adjustments to their thyroid until they've been on the estradiol for a couple of months, because you may find that you can actually lower their dose because they're going to be more functional. And they will also convert better from T4 to T3. So you don't have to add T3 either, because they'll actually make that conversion properly.
Mm-hmm. How long should a woman be on each dose of an estrogen patch before it can be increased?
There's no, it's very individualized, but I would say if they're doing, like if they're not doing well, like if they're still having night sweats or hot flashes, then I would like change it in 1 month. I usually have people come back in 6 weeks, okay, to give it a fair chance. So I would say like, you can change it in 6 weeks.
Okay, I'm pretty sure you answered this one, and I can answer this one. If a woman had a partial hysterectomy, do they need to take progesterone in the form of prometrium?
Yes, because progesterone, just like progesterone is neuroprotective. Progesterone helps maintain the myelin sheath that maintains neuron function. It's very good for the skin, for the bones. So it helps you sleep. It helps you to make GABA. So progesterone has many functions throughout the body. It's very anti-inflammatory. So it helps to suppress inflammation as well. So, and all of these hormones are fascinating. Estradiol and progesterone, that would be another whole lecture. They work intimately, interconnectedly with the endocannabinoid system. So you need to have progesterone. Progesterone, like every single thing in the body, is multitasking. There's no peptide that does one thing. There's no enzyme that does one thing. There's no hormone that does one thing. And progesterone does many things and is really a beautiful teammate of estradiol. And you definitely want progesterone, whether you have a uterus or not. That is a really important thing that our conventional medical world does not acknowledge.
Okay.
What is the role of phytoestrogens such as soy in menopause? Because now there's a lot of conflicting information. I'm not sure.
I love phytoestrogen foods. In fact, almost all the phytonutrients that are sold as, supplements, they're all phytoestrogens. I did a deep search on all of them. They're all phytoestrogens. Poor soy has been so maligned. It's just a bean, it's a soybean, and it's high in protein. It's very nutritious, but it's been, converted into all kinds of garbage, ultra processed food. But and it's, very heavily GMO. But if you get organic, non-GMO soy, and it's out there, and you get it minimally processed. So it would be only tofu, edamame, tempeh, miso. That's it. No other form of soy, not soy pretending to be hamburger, hot dogs, cheese, who knows what, right? Not that kind of soy, just regular organic soy, minimally or not processed. It's a great, isoflavones are great. Now, a lot of problems come in if you don't have the right gut microbiome, you don't convert the isoflavones into equal, but we're working on trying to get everybody's gut microbiome as optimized as possible. When you look at other phytoestrogens like the stilbene family, that's like red grapes, resveratrol is a phytoestrogen. So these are really important. If you look at quercetin, quercetin is a phytoestrogen, like you can find it in apples and garlic and onions. And urolithin A, I love urolithin A. I use the product from Pure Encapsulations because I like them, but they also have MitoPure from Timeline. But the urolithin A is a phytoestrogen, and it's predominantly alpha. That's what people don't know. It's more alpha than it is beta. Isoflavones are mostly beta. If you look at like the product Estrovera from Metagenics, that's from the root of the Siberian rhubarb plant, that is almost 100% exclusively beta receptor agonist. And then you have like from seeds, nuts and seeds, you have lignans. The most famous plant or seed that is lignan-full is flax seeds. Okay, so flax seeds are very healthy, and it can help women who are reproductive age cycle better, but not seed cycling, because that's, not evidence-based, but just eating seeds. And flax seeds, there's published data that it can help women with their fertility. Soy is a fertility food, okay? And there's actually the study that was done by, now I'm blanking out on his name. He's a vegan cardiologist who's quite renowned. And Neil Bernard published a study a few years ago where he took women in menopause who had very significant night sweats and hot flashes, gave them a cup of soybeans every day for 12 weeks, and almost 100% had almost 100% resolution of their night sweats and hot flashes. That's how great phytonutrients are, the form of phytoestrogens. I love them. I call it nature's gift to women. Because no matter how we give hormones, it's not the same as being 21. So we want to use all our therapeutic modalities, and phytoestrogen foods are a really big one. Plus, they have all this wonderful fiber that's going to increase GLP-1, and they have all the vitamins, minerals, micronutrients. So pro phytoestrogen foods.
Very good. Thank you.
Thank you. Can progesterone moderate excess estrone?
not especially, but it is useful. Not that there's any data on that, but progesterone is anti-inflammatory. Okay, and it can downregulate estrogen receptors. So, I mean, I don't think that if you have someone who is like massively or even significantly obese and is full of visceral fat and so on, that you just give them progesterone and they're going to like, get rid of all their estrone production. I don't think it's that good. That said, giving it with estradiol and doing all the other lifestyle things, you can. I believe you can. I believe you can get, the anti-inflammatory benefits in terms of having progesterone on board. But I don't know of any studies that show that it will lower estrone production. But when you think about it, I think it could be definitely part of the solution. Not the solution, but it could be a part of it.
Okay. If a woman has an ablation, how does she shed her lining if she takes estradiol?
There is no lining.
I'm asking the question. So, okay.
There's no lining. That's the amazing thing about an ablation. You literally like obliterate the lining. There is no endometrium. It's just myometrium, and that's it. There is no endometrium.
Okay. Can you still prescribe estradiol to women with endometriosis, adenomyosis, cycling it with progesterone?
Well, of course, there's no good published data, but the answer is yes. But you need to do everything to lower inflammation. I have not seen, because it's just not the same as having a reproductive age kind of hormone scenario. It is not. I have not had any activation of either one, but it is hypothetically a possibility to have activation of that. But it's not really highly probable. One of the reasons that women have endometriosis, we'll put adenomyosis in a different category, is because they have problems with their progesterone receptors and local inflammation in the pelvis and so on. And it's just a different scenario. You're not going to have the same degree of pro-inflammatory prostaglandins produced, because it's not really a menstrual cycle in the same way, so I have not seen that happen. But if you have a patient with a history of that, those are women you might want to give higher doses of progesterone. And I would always warn them, the same thing with uterine fibroids. I have had very rare problems. I can't say zero, but very rare problems of stimulating the growth of uterine fibroids either. But I think it's important that they are told that there is at least a hypothetical chance that you could activate those things by giving them the hormones. And then, it becomes a personal choice. And if they say, you know what, I don't want any chance, then obviously you're going to give them teensy doses. That's, that's what they'll choose, which is still better than no doses.
Okay. What about aromatase inhibitors in that scenario, or with uterine fibroids to shrink them?
Well, there's interesting with aromatase inhibitors that so inflammation upregulates the enzyme aromatase. So when you have inflammation in the pelvis, like with endometriosis, you have like extreme inflammation in the pelvis, it upregulates local aromatase in the peritoneum. And so you'll end up having like locally produced estrone. It's typically estrone from the precursor androgens from the adrenal gland. And so you end up predominantly with estrone in the pelvis, which then creates a lot of growth factors, which then promotes the growth of this endometrial implants. So that for endometriosis, it hasn't really caught on as a big treatment, but it has been proposed to give aromatase inhibitors. For uterine fibroids, you can actually have inflammation in the myometrium, which activates local aromatase in the myometrium to produce growth factors that stimulate the growth of the uterine fibroids. Giving hormones in the menopause tends to not create the same effect that I've seen, probably because the doses really are not you never get the spikes. You never have, it's not really as high as it is, and you don't have the same prostaglandins that are produced and so on. But aromatase inhibitors, there was one study I found a while back where they had breast cancer patients. They gave the breast cancer patients that had they had positive receptors for estrogen. They gave them aromatase inhibitors, and then they gave them hormone therapy. And guess what? They did great. They did fine. That never caught on in the oncology world at all, because what you're blocking with the aromatase inhibitor, just as you would with giving it to someone who has endometriosis, uterine fibroids, you're blocking the production locally of estrogen locally while you're still giving systemic levels of estrogen to all the other organ systems. I think it's a brilliant idea. I really do. But if you give enough estrogen, you're going to replace it where you need it, and then you block it where you don't.
Oh, sorry about that. Somebody talked in. Dr. Gersh, you're muted, unfortunately. Can you unmute again?
Can you hear me now?
Yeah, you're good. That was my fault.
Okay,
Sorry.
so no, I forgive you. You're a nice guy. If you want me to stop, just say we're done.
No. Somebody
Okay.
came in, and one of my co-hosts clicked the mute.
No
You popped up.
problem. But anyway, I think you're brilliant. I think that's a brilliant idea. It has been tested and I guess discarded, for breast cancer.
I've actually done
But
it about a half dozen times myself for patients.
Well,
we've actually done well with it. But for uterine fibroids, we've actually done quite well with it. If you shrunk them.
Well, it makes, when you understand that inflammation upregulates aromatase, I mean, the ultimate goal is to not have all that inflammation, of course, so you're not upregulating it. But at least short term, if you can, block the aromatase, you're going to block the estrogen stimulation. But then if you give back estrogen, at least you get it to all the other places that you want it.
Okay. What's your opinion of the Wiley protocol?
Go ahead.
So Wiley, I think, is brilliant, but not tested and not researched. And the dosings are completely off the wall in most cases. They're giving massive doses of estradiol. And I've actually measured people on them, and you can get levels like 800, 600. I mean, this is so.
I think remember the original one, they were giving 800 or 1,000 milligrams of progesterone every day.
I mean, the dosing is
20
massive.
years ago. Yeah.
But they still don't know. I mean, there's no published data. So I would say if you actually, because I think, mimicking nature is the best way to go. But if you really want to do something that's more Wiley-ish, then I would start with much lower doses than what was, recommended. Start much lower and then see how the person is doing. No one should go into that unless they're dedicated to working on rearranging doses and all kinds of things, and possibly having uterine biopsies if they have uncontrolled bleeding and ultrasounds, and figuring it's going to take a minimum of a year to try to get it right in most cases. So it's an enterprise, an undertaking that very few women will ever stick with and do.
Yeah. From what my understanding was, it was formulated by somebody that was clerk.
She has no medical background, but it's a rational idea. Okay. It's just hasn't been taken to any research type of depth, so, it's basically every patient becomes a little, experiment.
Mm-hmm. All right. What level testosterone do you recommend for postmenopausal women?
Well, there's no good data on that. The only approved use of testosterone in women is what's called hypoactive sexual desire disorder. And what the heck is that? It means a woman thinks in her head, I wish I wanted to have more sex, but I really don't, but I wish I did. That's hypoactive sexual desire disorder. So if a woman never has sex and she could care less, and she doesn't have that disorder. If she has sex once a week, but she thinks she should want it twice a week, but she really doesn't, then she has it. Okay, so it's a very weird condition. But in terms of, and that doesn't even involve levels or anything. So what I look at is a typical reference range for the reproductive aged woman. And so I like to go mid-range. Like, so I figure if they're in the single digits, when you measure testosterone, total testosterone, okay, if you measure total testosterone and the reference range is like, well, we'll say like 3 to 48 or something like that. You want to sort of be in the mid-range. If they're in the single digits, they're too low, and I think they would benefit from testosterone, especially if you got two different tests and they're 2 times, and then they both were really low, like in the single digits. If they're in the teens, then I would go by symptoms. Like, say you have a woman who has a history of hair thinning, androgenic alopecia, and acne. She may not really appreciate going on more testosterone because she may not like it. You might want to get sex hormone binding globulin, because 99% of testosterone is bound, 80% to sex hormone binding globulin. Little changes in sex hormone binding globulin will allow more free testosterone. But you can measure free testosterone, but it's not really, the numbers are so tiny in women that they're not really reliable testing, just so you know. You're better off getting you can get it, but it's not reliable. But you can get a total and look at sex hormone binding globulin. If it's in the bottom half, you're going to have more unbound, okay? So keep that in mind, because the last thing you want is your women patients to get more hair thinning, facial hair, and acne when they're, in menopause.
Yeah, that's
Think of like elderly women in a nursing home, that you've seen. They all have really thin, fine hair, and they all have whiskers. Like, do you think you want to give them testosterone? It's because they have such low sex hormone binding globulin that they have more unbound testosterone, which is what acts on the tissue. So it's a really finessing thing, the testosterone in women. But it has nothing to do directly with menopause. And in fact, testosterone production often increases in the early menopause and perimenopause because of LH going up. LH triggers the testosterone production in the ovary. So they may have elevated levels, plus declining estrogen will reduce their sex hormone binding globulin. That's why some women in the perimenopause, early menopause suddenly start getting facial hair and acne. They say, what the heck? So don't give those women testosterone, please.
right.
One question I have is breast cancer is getting younger and younger. Since the mid-1990s, it looks like it has gone up a lot. And I suspect xenoestrogens being the problem. What are your thoughts about it, and how do you prevent this early onset of breast cancer in young women?
Well, it's horrible, and it's complex. It also has to do with the gut microbiome. We know women who have breast cancer have a different gut microbiome, because it always becomes like, which came first, chicken, egg, the altered gut microbiome or the breast cancer. But we know that there's more changes in the gut microbiome in breast cancer. Early aged exposures to endocrine disruptors, set the stage. Like exposures in your teens can lead to breast cancer when you're 40. I just say, try very hard to avoid pesticide, herbicide. That's like some big problems. All the different endocrine disruptors, xenoestrogens. It's horrible, the increase in breast cancer in young women. And, nobody really cares, about the causation, like you're saying. It's it's like with colon cancer. Look at the problem with increase in colon cancer in young adults. Now they're talking about the gastric cancers are more prevalent in young adults with a higher rate of metastases and higher fatality rates. So we're getting all these cancers in young people. I think it has to do with having C-sections, not breastfeeding, lots of antibiotics, and all these endocrine disruptors that are interfering with normal immune function. And I sure don't have a good answer other than for every mother pre-conception to try to do everything to have everything organic, as natural, avoidance of chemicals through the whole pregnancy when you have gene, modification in terms of expression throughout all the critical stages of life and forever. I wish I had better answers.
Okay. We have a few more.
So should preconception counseling include organic foods and all of these things. And probably everybody should get preconception counseling.
Yes,
in this country.
100%, 100%. No, I mean, obviously many pregnancies are unplanned, but the reproductive aged women should know all this stuff. Yeah, absolutely. Because I mean, reproductive age men should know too, you know, but which is all men at every age, right, is potentially reproductive. But absolutely, preconceptual counseling can change the outcome of the whole life of the child and the outcome of the pregnancy that involves, of course, maternal morbidity and mortality.
Okay. We have more questions in the chat, but we have some online also. You know, we have I don't know if you know this, but we have a big crowd from the Philippines has joined us in the last few weeks. So, Dr. Nario, are you on?
Yes, I'm on.
Okay. Well, why don't you take over from now? You doing okay,
Okay.
Dr. Gersh? I mean, it's been
Well, I was just going to say, I think maybe another like to the hour would be okay.
That's fine. That's good.
Because my
All right.
husband might get mad because I'm not giving him any dinner.
Well,
Actually, he gives me dinner, but
well, here's some questions for you through emails. And one of the things that was mentioned there was I think you were a proponent of Prolon. So there was also a theory, I think I heard this also in IFM, that during the perimenopausal period, they were not promoting intermittent fasting because the stress on the gasping ovaries actually will increase the cortisol demands of that specific situation already for perimenopausal women. What are your thoughts on those?
okay. Well, during COVID, what happens when you do Prolon is that during the fasting portion, the the immune system actually goes down a little bit. The number of white cells goes down, and then it sort of springs back when you do the refeeding. So there was a concern that perhaps you may become more immune vulnerable when you're at like during the last couple of days of the fasting mimicking diet, because your white count actually drops and then it comes back. So in terms of reproductive aged women, the time to do any form of fasting, other than like fasting during the day, I mean, like not snacking, that kind of thing, but like in terms of many multi-day fasting, whether with water fasting or Prolon, it should always be done in the luteal phase after ovulation. They've had studies showing that if you do fasting during the follicular phase, you may prevent ovulation altogether, or you may have a lowered spike of both LH and estradiol and have a suboptimal ovulation. So we would only want to do any kind of real fasting in the luteal phase. In terms of perimenopause and menopause, I keep talking to Walter Longo. Hopefully we'll get some real studies done. But I never start people out on fasting mimicking diets until I've like prepped them to try to help them to be metabolically flexible, you know, so that they can convert from burning glucose into burning fat. It's not where I would start anybody, because you will fail big time. So I would want to get them first started on hormones for at least, say, 2 months, and have them do like a detox and have them get started on better lifestyle things, work on metabolic flexibility before I would touch going into a fasting mimicking diet, because you will have an unhappy patient and they will, I already found out the hard way. I learned this the hard way, okay, that they are just going to start eating, I don't know why this is, but it's like happened multiple times, peanut butter and jelly sandwiches. In the middle of Prolon, they just start eating peanut butter and jelly sandwiches. So don't do it. They will not be happy campers, and neither will you.
All right. Well, here's a dosing, maybe it's a regimen, a protocol clarification. So you're saying cycle progesterone. For estrogen, would you cycle that as well, or you just want to go straight from 1 to 30?
Well, normally I just do the same dose all the time, but anyone who wants to, if does everyone have my email? I think I had it on the last.
We can send it out. We'll shoot it out.
Okay, anyone who wants to, if they want to email me, I will get you a copy of my free menopause ebook. I'm happy to give that out
nice.
to anyone here. And I can give you the information. I'm not pressuring anybody, just for people who want to. I have a little hormone course that people can access, and it goes into a way of using like estrogen patches and progesterone pills to have a little bit of a cycling regimen so that it's a little bit more than just progesterone that gets pulsed. I call that pulsed progesterone or cyclic progesterone, but you actually have a little bit of hormone up and down during the cycle. For people, that's like, I'll call it for patients and practitioners who actually want to get a little bit more advanced. But I learned also that it's hard enough to get people to do much of anything, especially like having a period again, and because they will have a period, and putting up with that and taking the progesterone 2 weeks and then not being on it. It's hard to get people to do that, let alone have different doses on different days, But for people who are into like more advanced, I have it in my course, plus all the basics.
All right. For the people who actually receives progesterone initially and they have a reaction, what is the explanation for that?
Well, the biggest reaction is the sedation effect. They start making too much GABA, and so they get sort of dizzy or sleepy. So that's like the biggest reaction. It could be, if you giving like the commercial product, that they're reacting to the peanut oil or some other ingredient that's in the actual pill itself, the coloring or something else. So if they have a problem with the commercial product, I'll usually switch to a compounded one and then see how they do on that. I will, if they wake up during the night, they don't sleep through, then I will switch them to a compounded sustained release product. If they feel too groggy in the morning, as long as they're not driving or doing something amazingly important, I'll tell them to start taking the progesterone 2 or 3 hours earlier than they were, so that hopefully it'll be kind of worn off by the time they wake up in the morning. For people who, no matter what you do, they won't tolerate it, then you're stuck, okay? You either give them compounded progesterone cream, and that's really high dosing because the absorption is highly variable. We don't have any good published data. So you got to be willing to get ultrasounds and potentially endometrial biopsies because you don't really know how protective it is. And then the other option, if nothing is tolerated, it's not ideal, but it's something that can be done. One of two things. They can have a Mirena IUD. These are not my favorites, okay? But you can get a Mirena IUD, which will be uterine protective, then you have no progesterone, of course. Or you could do once every 3 months, a 2-week course of the progestin norethindrone at 5 milligrams for 2 weeks, just to shed the lining, and you live without the progesterone. But, you have to deal with reality. If people can't tolerate it, what are you going to do at a certain point? But those are two options.
Right. You mentioned about low doses of estrogen are inflammatory. So what is your recommendation of a good starting dose for your estrogens?
Well, if you have a woman that's only recently postmenopausal, I'll typically just start them, if I'm doing a patch, 0.1 patch, if it's a gel, the high, like 2 pumps, if it's estrogel, the 1.25 of the Divigel, because the highest dose is not really high. And then I tell them, if you have severe breast tenderness, it's not dangerous at all, but if it's a patch, just for now, for a month or 2 or 3 even, we'll just cut the patch in half, okay? Just see how you feel. We'll just cut the dose and see how you feel. I always warn them, that type of thing, that if they have too much for them, it's not really like it's too much. It may not even be a high amount when you test it, but they're, they're just extra sensitive and their receptors are sort of kind of getting rebooted and that type of thing. For an older woman, it's also variable based on their health. If they're really metabolically unhealthy, that's where the hypothetical risk comes in with an older woman. So I'll definitely work on all the different lifestyle things. In fact, I mandate it for them. They don't, other people, it's optional, but for them, if I'm going to be prescribing to someone who's 70 and they're metabolically unhealthy, they have to do what I say, or I'm not going to prescribe. Okay, it's hypothetical, but I'm not going to and a lot of the, by the way, they're showing that it may have to do with the gut microbiome, that there's any risk. So you really want to work on the gut microbiome big time, okay? And, check, for other measures of cardiovascular health and so on. And I will start often very low for those people. Like if I'm using a patch, it would be the 0.025 milligram patch. And but I'm going to try to move up pretty quickly, okay? Because I just want to see how they do. But I won't rush. I will tell them they have to do all these other things to improve their metabolic health. But in terms of like the more typical younger patient, I just usually start them at the highest dose. For compounded estradiol, I'll usually say, well, why don't we just try starting not too high, like maybe 1 milligram estradiol twice a day, and then see how you do, and we can rapidly increase it. If, you rarely have to go below that. The dosing is different for every way that you prescribe it. And topical bioidentical estradiol is not as well absorbed as the commercial products. So the dosing usually has to go considerably higher in terms of milligrams.
All right. Dr. Gersh, I think there's so many questions for you, but we want to be respectful of your time. It was a great presentation as always, and we'll definitely give you time to cook dinner for your husband. We don't want him to be angry at us, right?
Well, that's great. And this is another option down. I haven't planned it yet, but for those who are really interested in this topic in the future, I'm hoping within 2025, I'll create like some other courses and mentorships. So when that happens, I'll let you know, and then you can let the people know if they're even interested in such a thing. Then, because I really want to help.
Yeah, we'll send you the contact lists from tonight's participants also.
Okay. And then everything, it's just, I want to help people. That's why I'm here with you guys.
Okay. Well, it's
one last question is, how do we get more OBs to participate in functional medicine like you did?
Well, I am doing my best. I speak all around the world, often to OBGYNs, and trying to recruit them to understand women's bodies better. I mean, they're just not taught, And then you get crazy organizations like the Menopause who self-declare themselves the definitive word, and then they put out this crap, but I'm trying to counter that every which way. That's why I try to get articles published in mainstream journals to talk about hormones. And the editors are often really enthusiastic, and then they get hardly any readership. But I'm not giving up. I'm working on this. And there are a few other people out there in the world trying. So this is the data. It's so shocking. At the time of the Women's Health Initiative, just before it came out, at all ages, 40% of menopausal women were on hormone replacement therapy. It may not have been the right, but they were on 40% were on it. Today, in the group aged 50 to 60, it's only 4% nationwide. That's what's happened that's the gift of the gift that won't stop giving from the Women's Health Initiative.
One last thing before you give, can you make it just a comment on this business about you're only supposed to give hormones for 10 years after menopause?
Well, of course, that's absurd. The real question is how old is too old to start? And we can talk about that as well in the future. But in terms of continuing once they're on, it would be comparable to saying, when should you stop the thyroid hormone, right? There is no end date, because the hormones are always, well, here's a very good takeaway from that to end this. Every cell in your body is a different age. There's only a very small percentage of cells that were there the day you were born, right? A few, like neurons, myocardial cells. All the other cells of the body have died and been replaced at all different, speeds and intervals. So when a cell is born from a stem cell, it doesn't know how old the body is that it's inhabiting. They are genetically programmed to do whatever they're supposed to do if they get what they need, the right micronutrients, macronutrients, and hormones, and so on. They will do what they're programmed to do. So I have absolutely no reason to think that I should ever stop giving the right food, the right exercise, the right sleep, and the right hormones at any age, because all the cells are waiting to just get what they should get so they can do their job optimally.
Yeah, I mean, I agree. I mean, that's what I always say. So you're 65 and we're just supposed to stop everything? I mean, that's absurd.
Of course,
I mean,
like just put them in the grave and
yeah,
cover them. What? No, medicine writes people off at a certain age, and I don't agree.
yeah, yeah. So, okay. One last one. Uh, Perimenopausal female on hormones. Did she wanted to know when you cycle progesterone, do you mean 2 weeks on and 2 weeks off?
Oh, for perimenopause, if they're still having cycles, but they have symptoms,
Mhm.
then I go with their cycle. I try to match their cycle. Okay.
Okay.
If their cycles are really short, I will sometimes try to manipulate it a little bit. Like say they have a luteal phase that's only 10 days. Okay, something like that. I will still tell them to take the progesterone for 14, and I may manipulate a little bit to see if I can get them to have a little bit longer, like luteal phase. But I'm mostly going like paralleling their own cycle. So that's why I call it supplementation, not replacement. I'm augmenting, I'm giving them a safety net and trying to give a little raise.
Okay, great. Okay, we're going to let you go.
Okay.
I can't thank you enough, as always, Dr. Gersh. You're the best, and we love having you as always. So,
Well, it's my pleasure, and having so much interest in hormones is just really heartwarming to me because it's part of my mission and to create a legacy of having a whole bunch of people out there who
yeah.
love hormones and
Well,
want to give them.
Yeah, you have big fans here, so don't forget us.
I will not. You stay in touch with me, okay?
Absolutely, absolutely.
All right. Have a
Okay.
good night, everybody, or wherever you are in the world.
Yes.
Thank you. Thank you.
Okay, thank you. So just little bit of housekeeping. If you want CME credits, 2 AMA CME credits, by the way, Dr. Gersh. I can send
Oh,
you.
I want credit. What do I just do? Whatever. Let me know. Text me.
Okay, I'll send it to you. Okay.
Okay.
There's the
Yeah.
link right there. We get 2 AMA category 1 CME credits. It's $30 for 2 credits. And just there's the link. I put it on in the email every week, and one of these days I'll become unlazy and put it on the website also. With all the other ones that have been accredited for us. We've had a little hiatus there. Next week we have our own Stefan Hartman, and he is going to discuss apocalyptic medical necessities. So when the missiles are incoming, he's gonna teach us all about the what you need to have stocked up to survive the big one. Did I get that right, Stefan?
Yeah, pretty much.
All right, so that'll be next week. Anybody have any other questions? Dr. Peterson's here, Carol's here, and I'm here, and there were some more questions here. I don't, we're not Dr. Gersh, but there are some questions that weren't answered. Do you have any, Dr. Nario, that are left?
Yeah, there's some here still that I mean, it's something that probably she would also answer the same. So there was an issue, but was brought up here that when you have osteoporosis already, they're saying that the effect. This is conventional recommendations that they're not seeing any gel type of estrogen or cream type or patch estrogen that should be given to these patients. It's always going to be PO combined with biphosphonates. And that's I think that was the question, if that is something that she backs up. And they're saying that PO estrogen is pretty safe. So these are basically more of conventional recommendations. But in terms of osteoporosis, we still want to make sure we give our estrogens regardless, because whatever bone structure is left, it's still going to be maintained. That's why still staying, I mean, our caution will always be on the PO type of estrogen in relation to clotting. I don't know what your thoughts on that.
I have something to say. I did a big dive on this because a lot of these studies that came out were comparing oral estrogen, which happened to be Premarin, not estradiol, with topical, either the patch or the gels. And so they were coming up with all kinds of things, more fibrinogen, more C-reactive protein, but it was always Premarin. There are a few rare studies with estradiol versus estradiol, oral versus topical, and they don't look as bad. I tried to contact the drug company even to ask them about S-Trace and the generics. They've been on the market nearly about the same time as Premarin as oral estrogen, and they simply do not have all those effects that Premarin has. So I think oral estrogen is probably safer than we think. And I hate when they bring these studies out and say oral estrogen and it's Premarin and it's not estradiol. So a lot of the literature is very confused with that. So I agree. The other thing I want to say is estradiol is much more potent with for the bones than estriol. So I consider another reason why you might tilt that way. And let me see what else. Oh, you should not be giving estradiol alone like these women with hysterectomy. You're going to have an increase in prolactin, which is going to increase parathyroid hormone and pull calcium out of your bones. So we've done a big disservice giving women after hysterectomy estrogen only, telling them it's going to help their bones. It's likely not, and probably detrimental. Jerry Lynn Pryor uses, and she's the one who's really studied osteoporosis, and the big hormone there is progesterone, and she uses at least 300 milligrams daily for osteoporosis. So Dr. Gersh too doesn't, she doesn't tend to go higher. I was the osteoporosis dose, the studies were done with oral and oil, prometrium probably.
Yeah, and Dr. Pryor also, I saw one of her studies, 300 milligrams for migraines.
Yeah,
So
and for hot flashes too.
Yeah.
Yeah, it's we too many things are being credited as a estrogen deficiency. She's also published that in perimenopause, women have the highest levels of estrogen in their whole lifetime, and then contrasted with women starting to miss ovulations. So their progesterone is lower and lower. So this differential between the estrogen stimulation and the moderating effect of progesterone is lost a lot, and that leads to a great deal of symptoms.
Okay, Carol, do you have any experience with the cycling progesterone for menopausal women?
I agree with when somebody's cycling, just cycle along with them. That's what I think. But Ray Peat actually said something like, what should a menopausal woman look like? And he said, ideally, you'd have the same level of hormones as you had just before menarche. And that would be steady state. There's no cycling involved there. So I tend to favor steady state after menopause.
Okay. There's a question about the estrogen brand patch that causes less dermatological reactions. Does anybody have any answer to that? I mean, I don't.
I don't.
You know, usually we just get the generic, you know, that's usually what the patients end up with. So, okay. Are soy phytoestrogens binding mainly to beta or alpha receptors?
Didn't she answer that? I thought I heard her say beta.
Yeah. Okay.
Oh, you'll be surprised now. There's a company that's rallying for soy. So I was in that integrative dermatology symposium, and they're saying that there's no such thing as GMO soy. That's out there. And any soy that you see is always a phytoestrogen, meaning it's a healthy type of estrogen. So I asked them about that, and they just had this big debate about it. But just to give you a heads up, there's a group out there that's actually saying there's no such thing as GMO soy in the US.
It's well, it might not be GMO, but it's covered with glyphosate and stuff.
That too, huh?
Yeah.
There's also a group, and because I get an email from them. They're called the Immunological Group once a week, and they are there's nothing wrong with sugar. Sugar does not cause diabetes. Sugar does not cause obesity. There's nothing wrong with glyphosate. It's just been demonized, and there's nothing wrong with it. Hormones, of course, bioidentical hormones, of course, are bad. So I'm actually trying to get somebody from there to come on and give us a talk. I think it would be interesting. So to listen to them. And since
Yeah, I think soy is the number 2 GMO in the country, actually, after corn. It used to be sugar beets. That was number 1 GMO. That's what Monsanto started with. But then corn took over, and soy is number 2. So whoever says soy has no glyphosate in it, that's that's a nonsense. I don't know where they're coming from.
okay, somebody asked.
I'll get the company. We can throw
Somebody asked if
tomatoes
there are
out.
protocols or suggestions or trainings for individualized hormone supplement replacement. Well, I have one actually. Dr. Gersh has one, and I'm sure Carol has one also. There's quite a few out there. I do have one. So if you want to get in touch with me, we can get you some information on that. She asked. Someone asked, "Do you recommend DHEA and pregnenolone for complete hysterectomy patients?"
Sure.
Yeah. Yeah. Okay. Again, everything
Yeah,
balanced.
Yeah.
Okay. So Dr. Quinn says, I hope everyone heard additional therapeutic pearls, including detox, diet, exercise, and stress management. Too much to mention in one hour. Is there a danger of giving progesterone in menopause? No. No, we do it all the time. We'll get question about Dr. Gersh's talk. We'll get you her contact information if you're interested in it. Lots of kudos for Dr. Gersh. It's a question about how much is that dude being paid? I don't know what that means.
No, for the soy, I think.
The soy.
Dude,
There was a guy named Mark Messina who headed up this. He got paid big bucks to promote soy.
Yeah. Okay. I don't know.
He-
Okay. You got any more questions, Dr. Nario?
One thing I just want to give everybody another heads up about what's coming in the pipeline, bioregulators. So these are what they're saying that's going to be a replacement or even an upgrade of our peptides. And this is being started by Dr. Kent Holtorf here in the US. And an example for that would be the bioregulator for ovaries. If you actually have somebody who has ovarian dysfunction, or of course, who doesn't, you give this bioregulator and it will modulate. So it's not going to be something to hyper or hypofunction it, but it will regulate a specific organ. So it's also coming in the form of course, pancreas, thyroid. So it's actually the organ, and this is actually being originated in Russia, and now it's being brought here in the US. So that's something they're already starting. I think Integrated Peptides has some of these products. I just don't know what the whole lineup would be, but it's definitely interesting and worth looking at in the future.
Are they nucleotides? Does he use the word nucleotides?
They're saying it's smaller than the amino acid formation of peptides. So it's still amino acid based. There's more questions, Dr. Bill. There's some stuff popping up.
I think I got all the ones that I have here. Do you have more?
Yeah, can menopausal women have estradiol without progesterone? We don't want that.
No, the answer is no.
Yeah, and Dr. Miller, I meant progesterone only without E2. Yeah, during on postmenopausal. Yeah, that can be done. I've done that.
Yeah, we do that all the time. So.
Yep, and yeah, that's it on my end.
Okay, great, Dr.
Here's a tip. Here, Dr. Clearfield, another tip for everybody here. There are studies out there, and Belmar actually presented this, that GLP-1s will work better when you're actually on bioidentical hormones. So that's also a key, I guess, synergistic approach that everybody should be doing when they're using GLP-1s on their patients. It's going to be way more effective, as mentioned by Dr. Gersh.
Okay. Do we need we had a couple of talks on GLP-1s. Do we need an update coming up soon? Is that?
Yeah, I'd like to know if that calocarb is working well in your protocol, Dr. Clearfield.
Okay. Yeah. We're still going strong with that. Okay. We use it
It seems
independently.
more physiologic than the injections,
Yeah. So we use
which
it independently.
would
We'll sometimes use it for maintenance.
uh-huh.
So we use it for both. We use it with a combination of a couple of other things. And we do real well. And I know I mentioned it, but the magazine came out. I don't know if you can see it. Best of Sierra, which is the Reno area. The number one weight loss clinic in the Reno area is Clearfield Medical Group, by the way. So, page 35. right there, page 35. That and 15 cents will get me nothing. Right.
Thanks to CaloCurb, huh? And high phenolic.
CaloCurb, right. So no, I think I went over it once. I mean, besides the GLP-1s and the CaloCurb, and we use a couple of other AMPK stimulants. We have a pretty nice online program that we use. We use that Body Sight program that we presented here for patients. Then they have meal plans specifically for GLP-1s. We use those. You can write your own on that also. We've come up with a protocol for post care so that you don't gain it back. That's always a big issue. So if we want coming up, we're booked up and pretty much through the middle of November now. But if you want some, maybe we can do that maybe 2 weeks before Thanksgiving. Okay, that'll be a good time for that.
Yeah.
So, John, what's happening at the medical school?
Everything this way is beautiful, and I'm once again amazed by this group. What a team.
Yeah, we're doing well. So again, October 30th to November 3rd in Salt Lake City, Age Management Medical Group. I'll be speaking on longevity on Sunday. And it's a smaller group than A4M. It's a lot more intimate. I think we get a lot more out of it. It's not nearly as frenetic and crazy. And there's much a lot of good camaraderie there if you're interested. It's at agemed.org, AGEMMED.org. It's moderately priced, we usually have a good time with that group. John, were you involved with OMED at all? Did you have any contact with them?
Nothing whatsoever.
Okay, yeah. So that was the AOA's scientific thing where they have 5,000 doctors. They told us not that, they kicked us out and then told us we could come and then don't come. So, and they sent personally sent me, I got a letter from a lawyer, a cease and desist letter, and said that I was not to go there because I don't know how to behave, quote unquote. So
Oh, you mentioned A4M. October
Yeah,
7 to 20, we'll be lecturing with the faculty of A4M for women's hormones. Anybody interested?
Yeah, it's an online a program. It's a little pricey, isn't it?
It is. That's not my call, though.
I know.
Oh, and one thing, I'm gonna be going to Germany for Medicine Week. Anybody who's going to Germany, that's gonna be. I think it's gonna be at the end of November, October to early November.
It must be nice to be single and young and be able to travel. You just got back. You spent a whole month in the Philippines this summer, and now you're going.
It's just a few days.
Huh?
It's in Baden. So I hope I can understand German, but I'll take a risk. I'll roll a dice for that. They said it's good stuff over there.
I went one time. They have translators.
Oh, good. All right. Thanks for that.
Okay.
Yeah.
So one last thing.
Updates.
Amber's our patient, so she's been on. What did you think of what you heard tonight? You're muted.
Well, A lot of it because I have the PCOS and the other estrogen issues. I found some of it contradictory because I had my first child at 39 and I had my second one at 40, and I did both of those naturally without assistance with PCOS. And I'm overweight and I'm not in her criteria for having children, especially late stage children. So it was
Yeah, we have to remember that
informational.
when we talk about,
What's
when we
that?
talk about these things, it's it's a percentage. It's not any one individual, right?
Yeah.
So
I was like, I'm the exception to all of her rules. Like,
yeah, yeah, and
like everything else.
and that's okay, and that's okay.
Yeah.
Yeah,
I didn't have I didn't have gestational diabetes. I didn't have I at 39 and a half weeks with the first one, my blood pressure went up at the end. And then the second one, because I took I took two supplements. I'm brain farting on what they are. But I think it was L-tyrosine. Anyways, for the second one, I didn't have any blood pressure issues. But with him, he was just the first one was 8 pounds, 13 ounces. We didn't have any growth restriction. The second one was 10 pounds with excess amniotic fluid, and the largest placenta any of the staff had ever seen. So there was no growth restriction with him either. So overall, I mean, I did have a question with the GLP-1. She was saying that you shouldn't give the GLP-1, like the Wegovy and all that, without supplementing estrogen. But does that apply to people who are estrogen dominant? Which obviously she said you're not supposed to say estrogen dominant, but I mean, I'm estrogen dominant. That's what I've been diagnosed as. So which estrogen I am dominant in, I don't know. So I'm just going to categorize it as the family of estrogen. But I mean, does that apply? Should I be supplementing with estrogen if I ever get a
if you're
GLP-1?
estrogen dominant, you have more estrogen than you need. So I would think not.
Yeah. Yeah, that was my question. I typed it in, but obviously she got bombarded by a lot of information with a lot of questions.
Yeah,
so my question.
Yeah,
got
we could
bypassed,
listen to her all day. So
yeah.
All
So
right.
yeah, I mean, that was my only question was that, I just was like, well, that doesn't really apply to me. Here I am with another exception to her rule. So
Yeah. Well, there's always there's always that. So
yeah. Well, that's why I'm on here, because I'm a mystery. So
What she probably meant by that is when you optimize your estradiol, GLP-1 receptors are more potent and more active. That's why
Right.
when you use your GLP-1s along with balanced hormones, you will definitely get the maximum effect of your GLP-1s. I mean, I don't think it was meant to be saying that it's going to be bad for you to start GLP-1s with estrogen dominance, for the reason that a lot of our GLP-1 patients are already overweight and they're very estrogen dominant, meaning mostly estrone probably, but it actually helps regulate all of these hormones and the abnormalities once you get on GLP-1. So I don't think that's what she meant by that.
Oh, okay. Yeah, I was just curious about that because I was like, well, I want to go on them, but I'm still breastfeeding. So I've been breastfeeding for over 4 years now, and so I was like, well, I can't take it until I'm done breastfeeding anyway. So, but I do have the midsection weight, but I've always had that because of the PCOS. So it's like, but now I'm up 30 pounds compared to what my body considers my normal. And it's stuck. It's not going anywhere. No matter what I do, it's just stuck there. But I'm also 43 now. So
yeah, well,
yeah.
We'll think of something.
Yeah.
Dr. Bill will take care of that.
We'll think of something.
I hope so. But yeah, so
we have this huge huge community here. Somebody's got to have an idea out there. So
yeah.
All right. Anybody else have any comments or questions? We've been on for 2.5 hours. I think that's a good run. All right. So if you want to find out what
one of the things that are clear here, we never talked about testosterone and osteoporosis. Which one builds bone better, estrogen or testosterone?
Something just
that's a good question. There's not very much literature on testosterone or DHEA. You would think the anabolic effects would be beneficial. The big research is on progesterone and growing new bone, estrogen slowing down the rate of bone loss. Theoretically, you would think it would help, but I haven't seen a lot of data on it.
I have some studies. I'll pull them out and I'll get them to you. So Okay, what does one work better than the other? I really, that I don't know. Usually it's, most of the time we're, especially postmenopausal, we're using both. So it would be a cumulative type thing, I would
Well,
think.
what's
Does
striking
anyone follow?
really was when
I'm
they
sorry, does
saying
anybody?
go ahead, yeah.
I was going to ask if anybody follows Dr. Barbara O'Neill. Is anybody familiar with her?
Yeah,
The Australian lady?
Yeah.
Her big thing about osteoporosis is that we're not made of calcium, is that we're made of the 12 minerals. And so I've actually started supplementing my water with the Celtic sea salt, or the Baja Gold salt. So, because I know that breastfeeding long term, my bones are probably at risk, with those nutrients being depleted. So that's what I've done, just based on, her information.
What was
Actually,
surprising about with the new recommendations for osteoporosis is, again, I think I mentioned this a while ago, that when you're in osteoporosis, the new recommendation is saying estrogen couldn't even do a thing. You need bisphosphonates for that. Though, so these are conventional recommendations from the recent AANP conference. That's why, as we now live in our integrative world or bubble, we definitely say that this needs of that, and there's still some hope for estrogen on our end, of course, in different methods and how we want to give it.
yeah, progesterone too. Actually, Alan Gaby wrote a good book many years ago, Preventing and Reversing Osteoporosis. You need the minerals, you need protein assimilation. It's not just calcium sitting there.
Right. And if you go on our website, Amber, aosrd.org, there's a couple of lectures by John Neustadt, aosrd.org/webinars. Look up John Neustadt. We've had him on a couple of times, and he's got a whole protocol that he's going over with us. Okay.
And we
NEWSTADT.
NEUSTADT.
Okay.
We also have Designs for Health. It's electropure hydration. It's pretty decent. It's not as strong as LMNT. It's 500 milligrams sodium, 500 milligrams potassium, 100 milligrams magnesium. Tastes good. And I think it's really decent, just to say, to add the electrolytes back into the body.
So, all right. Okay. Anybody else have anything else? Be well, and we'll see you again next week, same time, same station. Bring one friend, we'll double our census, and take it from there. Thank you all for everybody for being on, and stay well. And anybody has anything to present, they want to present, please let me know. Again, CME credits, it's still in the chat. And it'll be on the email, next week's email, how to get it also. Okay. Thank you for being with us, Amber. So welcome anytime. Okay. Good night, everybody.
Good night.